Why don't we get started? Good morning, everybody. Welcome to another UofT Department of Ophthalmology Grand Rounds. This morning, I would like to introduce two of our faculty members, the first of whom needs no introduction at all. I think everyone knows Dr. Sam Markowitz. He's a full professor of ophthalmology at the University of Toronto and absolutely a world-renowned specialist and scientist in low vision rehabilitation. At this point, Dr. Markowitz's practice is strictly limited to low vision rehabilitation, where he uses the most advanced techniques for diagnosis and rehabilitation for our patients. He has a long track record in clinical practice with many achievements, and as a result of this, he's garnered this international reputation and has been a wonderful mentor and teacher to many generations of residents in our program, including myself. So Dr. Markowitz, thank you for joining us this morning. And through your fellowship, you have brought us Dr. Monica Naidoo. So Dr. Naidoo is an ophthalmologist who initially completed her training in Brazil, and practiced as a pediatric ophthalmologist and strabismus surgeon at the University of Sao Paulo in Brazil. She subsequently came to Toronto for a low vision rehabilitation fellowship and was so excellent that she was recruited back to the University of Toronto, where she has remained and is on staff at the University Health Network. And she's been a real dynamo in our department and a great addition, and has been helping to revamp our resident low vision program as well. So Dr. Naidoo, thank you to you as well for joining, and I'll hand the reins over to you both.
Thank you, Dr. Rai, for your kind words and introduction. I'd like to acknowledge Dr. Mizawa, our fellow for low vision rehabilitation, who helped us to prepare this presentation. And actually, she was just accepted for a fellowship at the Sick Kids Hospital. So congratulations for her. And also we have the pleasure to have the two PGY2s, Dr. Melan Shu and Dr. Tina Felfelli. Our residents, they voluntarily went to our service at the clinic in low vision rehabilitation. They saw patients, they filmed, they studied with us, and they're going to show today what they learned from pediatric vision rehabilitation and vision rehabilitation in general.
Excellent, thank you. So we'll get started. And Mariana, congratulations to you. That's a wonderful accomplishment.
Thank you.
Okay, so you can go next. We don't have any financial interest in this presentation. We would like to thank our colleagues from the Sick Kids Hospital who referred the patients to our low vision service. As they referred the patients, they made this presentation possible and our work possible. Today, we're going to start with introduction to low vision, the concepts in low vision. Then we'll show you how we assess your patients when you send them to us. We'll talk about what people do for vision rehabilitation in children all around. But we have some new interventions that we do at the University of Toronto that we are very excited to present to today. It's kind of exclusive yet, but we want to broadcast that. And we are going to have many cases discussions during the week.
So I'm Tina Felfelli, a resident physician in the Department of Ophthalmology and Vision Sciences at University of Toronto, and currently in the second year of my ophthalmology residency. It's a pleasure to present to you today. I would like to start this presentation with some success stories of what patients who have benefited from low vision rehabilitation have experienced at our institution. Meet patient A, who's pictured here with his mom, who was diagnosed with foveal hypoplasia. When he was diagnosed, patient A was told that he would never be able to gain 20/20 vision. However, after receiving low vision rehab for 6 weeks, he was able to see 20/20 and read much faster at school. And now he hopes to be a game developer one day, a dream that may have not been possible for him without low vision rehabilitation. I would also like to introduce you to another patient with the diagnosis of foveal hypoplasia. After low vision rehabilitation services, she now feels that her career choices and lifestyle are no longer limited by her disability. And she describes it as if a light switch has gone on. These are just some of the examples of what low vision rehab can accomplish. And we will revisit some of these cases in more detail throughout this presentation.
Good morning, everyone. I'm Manlong Du. I'm a PGY2 ophthalmology resident at the University of Toronto. Very nice seeing everyone and joined today's presentation. So now let's put on our first poll questions. As we are talking about low vision, so what's your understanding of low vision? Is it best corrected visual acuity equal or worse than 20/50 that cannot be corrected by eyeglasses or medical surgical treatment? Is it B, loss of visual field, reduced contrast sensitivity, or increased glare? Or is it difficulty with activity of daily living caused by vision loss, even if the visual acuity is better than 20/50? Or is it the final choice, any of the above? Let's give the audience some time to put on their answers.
All right, I'll share this with you. You've got a bit of a mix, but all of the above seems to be your most popular answer.
Great. I think yeah, most audience select the right answer. So yeah, here is the correct answer for the definition of low vision. Just remember, any one of them would fulfill the definition of low vision. How about legal blindness? In North America, the legal blindness is defined as best corrected visual acuity of 20/200 or worse in the better eye that cannot be corrected by medical or surgical treatment or by glasses, or a visual field deficit of tunnel vision with a diameter of 20 degrees or less. Just to remind everyone that the World Health Organization has its own different category of definition of low vision, which is different from North America.
So for our second poll question, I want to ask the audience what they think is the prevalence of low vision in the pediatric population in Canada. Is it 1 per 10,000, 4 per 10,000, 13 per 10,000, or 52 per 10,000 people? And if you have to guess, that's also okay.
You know, Tina, this is giving me nightmares of OCAP questions right here. All right, we're for the sake of the audience, we're going to call it here.
Okay, so we again have a mix of answers, but it seems like 4 per 10,000 and totally guessing are the winning answers here. So we'll give you the OCAP answer this time. So it depends on the definition that's used. The prevalence of vision impairment for the pediatric population will be different depending on the definition. And so according to the World Health Organization definition in regions of Canada, the prevalence is estimated to be 4 per 10,000 people. Comparatively, the prevalence is higher based on the North American definition, which estimates a prevalence of 13 per 10,000 people. And so the 3 leading causes of pediatric blindness in the United States have been reported to be cortical visual impairment, ROP, and optic nerve hypoplasia. Based on our experiences at a tertiary care center with low vision rehabilitation services in Toronto, the most common referred diagnoses are foveal hypoplasia, nystagmus, Leber congenital amaurosis, retinoblastoma, brain tumors, and toxoplasmosis with macular scar. Recent reports have noted that less than 5% of patients with low vision can access low vision rehabilitation services in Ontario. Some of the important barriers to accessing low vision services across Canada have been identified in the literature to be lack of awareness about the benefits of low vision rehab and limited collaboration between eye care and vision rehabilitation services. So through this presentation, I really hope that we'll be able to increase awareness and excitement about the benefits of low vision rehab for pediatric patients.
So we are privileged in Toronto because we have a tertiary service for vision rehabilitation at the University of Toronto. And this is our team dedicated to low vision research at the Toronto Western Hospital. Dr. Samuel Markowitz, Michael Reber, myself, Dr. Mizawa, our fellow, Dr. Michelle Markowitz, optometrist, and we develop a lot of research projects, really. And when you send your patient to us, we're going through many different tests, detailed tests for the visual functions. And let's go through the tests now. I'm going to illustrate how we measure the visual acuity. It's a little bit different from the clinical practice, the general practitioner. We measure with the ETDRS chart, which is 100% contrast. So this is the reason why you may send the patient to us as a 2400 visual acuity patient, but we may find 20 over 100 or even better sometimes, because this is a better test to disclose the vision of the patients. We also do refraction on a different way. We frequently use the retinoscopy for testing the children and even adults, and we use a trial frame. This allows the patient to turn a little bit the eyes or the head and use their eccentric viewing. So nowadays we use the MN-Read test on the iPad to measure the reading speed. With this test, we are able to check the smallest print size read or reading acuity, the maximum reading speed. This is the reading speed when not limited by print size. This is the result from the test that we get. But the test also shows you the critical print size, which is the smallest print size that supports the maximum reading speed. The microperimetry is a very important test for us because this is how I tell the patients why the way I can know how your vision functions through this test. It shows the scotoma size, the true scotoma size, because it has an eye tracker. And if the patient loses the fixation, the test just stops waiting for the right fixation. It shows the retinal sensitivity over all these points, 20 degrees around the fixation point or PRL. It shows the PRL location, which are these blue dots here at the center. And the area that comprises these points are the fixation stability area, through which the machine can calculate the fixation stability value. The greater the area, the worse the fixation stability. It means the patients are wandering to see. And altogether, we can assume what is the functional retinal location of the patient. Also, we test the contrast sensitivity with different tests. For research, we may use the VCTS test, for example, which gives us 5 channels of frequency. For a screening test, we use the Cullen-Brender that we presented last year here in the rounds. We can also use the Mars test for research. We frequently test the color vision. For chromatopsia, we use Ishihara test, but for more complicated cases, the matching test. Sometimes the stereopsy is needed to be tested. We have Frisbee, we have Titmus test. So traditionally, we have some interventions in pediatric vision rehabilitation. As Dr. Markowitz said, not everybody does this kind of vision rehabilitation for children. They are sent to the Vision Loss Rehabilitation Canada, where they go directly to the computer stuff, but maybe they don't even need that. They need more simple interventions. For example, they can have handheld magnifiers, or most commonly the stand magnifiers that stand over the material and to magnify things. They can have telescopes for seeing the board, as you see here on the left superior part. They can have selective transmission lenses that are colors filters we put on the lenses to filter the wavelengths, improving the contrast sensitivity and cutting the glare for photophobic patients. For example, chromatopsia patients may benefit from a blue filter or a red filter, and we have this in our service to help them. They can read better, sometimes with a greater addition or spheroprismatic glasses that may come ready, or we can prescribe them customized. And rarely we can use the microscopic lenses that are monocular. They go up to 30, while the glasses, the spheroprismatic go up to 14. Microscopic lenses go up to 32 or 30. And the high-tech, the most commonly used high-tech aid is the smartphone. To tell you the truth, every child has a smartphone from 4 years old now, and the iPads, tablets. So this is a very useful way to magnify, to take pictures from the board and to study. So they use it a lot. We have in our clinic the eSight, which is a head-mounted video magnification, has cameras binocularly and magnify up to 25 times the images. Sometimes the children like it very much. The problem is the cost. We have also CCTVs to show in our clinic, portable smart lux, for example, which magnifies on top of the material on a camera, offering the patient more contrast and colors, reverse polarity, helps a lot with reading. And for the class, they may use computers to take images from the board and magnify on the computer. And the children with blindness, they can use audiobooks or CD, other audio resources. So when you send our patient to our service, as I said, they are going through all these tests, but first of all, we establish the goals with the child and the parents or adult. If they want to cook, if they want to study for school, to see books, computer, what's their preference and their needs. We assess the cognitive states of the patient, if they are really able to cooperate, to understand, if they are still in denial, maybe they are not ready for vision rehabilitation yet, but we are going to book another appointment and follow these cases as well. If the patient is ready for vision rehab, after the test that I mentioned, we're going to choose with the patient the best intervention. It can be a better refraction to start with. It really improves up to 11% of the cases with low vision, because we do in a different way the refraction in our service. Also the increased add, we're going to a +4 add or more. We can prescribe that. We use frequently prisms to relocate the images to the preferred retinal locus, and we are going to explain about that. We use field expansion prisms to improve the fields of vision. And we use prisms for abnormal head position compensation. And we're going to show this today as well. I showed here the optical aids we can use for the patients, electronic. We can use filters I showed as well. And the patients go to a multidisciplinary team after we do the medical interventions. This is very important. The correct way vision rehabilitation should be practiced is starting with the ophthalmologist or optometrist, and then after all these interventions are decided, they go to a multidisciplinary team to see more computers. Then they go to their home, they explain how to use a white cane, they have courses, softwares for computer magnification and audio. So this is all after the medical doctor. Because now we are working a lot with biofeedback training, which is a life-changing as well intervention if we know how to use it. For some patients, it helps a little bit, for others, it can help more. The patient to do biofeedback training has to have a good cognition, has to cooperate, especially children, we select a little bit that. We try. They have to have a good area of retinal sensitivity to be trained, or unstable fixation that can be trained. There are cases that are not very good for biofeedback, such as ring scotomata, poor cognitive skills patients, and if the PRL or fixation point is more than 20 degrees from the fovea, or if we need to relocate more than 20 degrees, usually that does not go well. So we try sometimes, but it's not a good case.
Okay, now let's look at what are the new interventions in low vision rehab that we have in our service. So let's start with our first case. So this is an 8-year-old girl with idiopathic infantile nystagmus. And as you can see here, she has an abnormal head position, which is 20-degree right head turn. Here is her assessment. So her refraction at distance was +3, +0.25 times 100 degree with a distance visioned at 20/50 for the right, and then +3.75 was visioned at 20/70 for the left, and binocular vision at 20/32. Her stereosis is 30 seconds, so which is normal, and she also has a good contrast sensitivity as well. However, her fixation stability was quite poor, so it measured as 7.2 square degree as the BCVA area, which we're going to talk more about later by Tina. Usually the normal area is about 0.5 square degree. So it's quite enlarged with quite poor fixation. Her reading speed was reduced as well at 84.2 watt per minute, and her near vision was 20/32, measured by the critical print size. So firstly, our intervention for her reading was to add a +2 diopter, and which improved her near vision. Her critical print size improved to 20/16, which was 3 lines improvement, and her reading speed was improved as well. Usually the first thing that we did in our low vision rehab service was to prescribe addition in pediatric population. Children are different from adults. They have a great range of accommodation. So they can be vary from +10 to 0. And therefore, it's very important to assess their reading skill and to measure their accommodation and try to prescribe ads to improve their reading and studying quality. These ads can be prescribed as bifocal or as a separate pair. So depending on the profile of the children and what they preferred. So let's look at the abnormal head position in this case. So we decided to use prism to correct the abnormal head position. So we started with the smallest prism, and as we can see in the image there, so the apex of the prism point to where the eye position is. So we started with the smallest and gradually go out in prism diopter, and depending on so how much the patient can accept and what is needed to correct the abnormal head position. At the end, it was 5 prism base out for the right eye and 5 prism base in for the left eye. That was able to correct her abnormal head position fully. So as we know, the light bends towards the base. Therefore, the eyes refixate to so the eyes move to refixate, and therefore the abnormal head position corrects. As we can see here at 2-year follow-ups, so the image on the left shows that the patient without the prism, and on the right with the prism. So her abnormal right head turn is corrected almost fully with very little bit of right head tilt, and she was very happy. This is another case. So it's a 40-year-old boy also with a little bit of abnormal head position, as you can see here on the image on the left without prism, and the image on the right was prisms. So it was 4 prism base out and base in, and this is 3-year outcome. Here is another case, 12-year-old, 3 prisms base in and base out. As for the image without the prism on the left and with prism on the right, was fully correct so his abnormal head position. This is another case, 11-year-old boy with prism, 3 prisms base in and base out. As you can see, the image on the left without the prism and on the right with the prism was fully correction of the abnormal head position.
So we took a look at our cases when we started doing this and saw it was working. The first 9 cases we saw had many different diagnoses and different measures for the abnormal head position, from small, medium to large. We fitted from 2 to 5 prisms yoke, and it corrected from 70 to 100% of the abnormal head position, mostly 100% of the abnormal head position. And now we started measuring our cases, and we measured 13 more patients, and we calculated they are improving average for distance from 19.6 to 6.6 of abnormal head position, and for near, similarly, from 18.6 to 6.4. The average of prisms used, the amount was 3.9 prisms diopters, and the P was significant for distance and near improvement. So this is not a new treatment, actually, but in the literature, I could find only higher values of prisms used, and mostly for nystagmus that dumps in convergence. So it's a little bit different. The doctor adjusts 7 prisms base out, with a -1 sphere to compensate for accommodation. And the patients also improve. But for some reason, we received more patients for yoke prisms. And instead of adjusting 10 prisms as Del also studied and others in the literature, we started to reduce this because the higher number of prisms produces some side effects. Correcting the head position is not just aesthetical, it's also for the visual improvement, because there is less effort to see and more is visualized in a glance. And it removes the effort to concentrate, avoiding the intensification of the nystagmus. I believe many here has examined a child whose mother is saying, look, pay attention, pressing the child, it will only make it worse. So I had a lot in the past. So the prisms can also be used postoperatively, but this is the limitation. They cause prismatic aberration if the value is more than 6. I don't like to use it.
So now that we've gone over the use of prisms, I'll next discuss another set of new interventions in low vision rehabilitation for pediatric patients.
Sorry, Tina, before we go on, there's a comment/question in the chat from Dr. Kraft that perhaps we can address now. Dr. Kraft mentioned he's surprised by how significant of a head turn you can correct with such low magnitudes of prism power. Monica, do you want to expand on that?
Yes, I am surprised too. It was something we tried and observed. And as we see, the eye movements can correct and adjust with a small amount of prism, we can compensate. It leads us to think that the brain and the eye does the rest. The muscles adjust to the small amount and they can really improve this head position. This is our theory. You're mute.
Yeah. I'm sorry. And do you think it has to do with the fact that it's a pediatric population?
I don't think so, because we have tried with adults and it works the same way. We didn't measure yet with adults, but I'm going to.
Okay, well, looking forward to that talk. Dr. Markowitz, go ahead.
The secret or the mechanism for the improvement is an improvement in fixation stability as measured with microperimetry. So the improvement in fixation stability does not have a linear relationship to the amount of deviation and prisms. Some people with a small amount of improvement in fixation stability will correct larger deviations. So that's probably what's intriguing. But we learn more and more that fixation stability really is the key to many aspects of improvement in visual acuity, or in this case, appearance and muscle alignment. Thank you.
Thank you. Sorry, Tina, go ahead. Sorry about the interruption there.
Not at all. And that's actually a perfect segue for us to talk about some of the next set of interventions that we're using in low vision rehabilitation that really involve fixation stability. So in order to discuss these other interventions, I'll first introduce you to some concepts and terminology such as PRL, which you heard earlier in the presentation. PRL, or preferred retinal locus, refers to a retinal locus that could fulfill the function of a pseudofovea after loss of fovea, as it may become the new reference point for oculomotor system and may be used consistently for performing visual tasks. PRL is typically recorded during a fixation task, and it's defined by two measures: the absolute location on the retina and the fixation stability. Here you can see the PRL outlined with the circle on the right side, which denotes the PRL based on the fixation points detected for the patient during a visual task. Note that this does not correspond to the fovea, which is lost due to a macular scar in this particular case. So patients may have one or many PRLs for various visual tasks. The PRL is a circumscribed region on the residual functioning retina. The oculomotor reference plays a role in the PRL development. The brain has to recognize the PRL and balance the extraocular muscles to be on that position. The oculomotor reference changes when the PRL is not functioning well, and the brain may actually have a harder time finding the new PRL. So when assessing the location of PRL with microperimetry, we can see areas of high retinal sensitivity, the location where most of the fixation falls, and the functional retinal areas. You can see each of these concepts and associated locations outlined on this image: the HRS, the PRL, the FRL, with the HRS being the area with the highest retinal sensitivity in terms of decibels on microperimetry, and FRL being the areas of retina that have good function. So frequently, the PRL adapted by the patient is not a suitable area for reading or for various visual tasks. The TRL, or trained retinal locus, refers to a new PRL that can be chosen for the patient and can be trained to improve visual skills. So when selecting the TRL for a patient, it's important to consider areas with the highest retinal sensitivity. The superior, followed by temporal, nasal, and inferior are preferred because of the associated field and appropriateness for reading tasks. It's important to always prioritize the eye with the better visual acuity or the bivariate contour ellipse area, which I'll discuss shortly. Also prioritizing the better span for reading for the PRL in the better eye. And if multiple areas are suitable for PRL in both eyes, then always choosing the one most suitable for better binocularity. When selecting and training for TRLs, we avoid training both eyes as it may lead to diplopia. And finally, an important consideration is that the worse eye provokes binocular inhibition in a third of the cases, and biofeedback training is expected to help with that phenomenon. Here are some examples of patients with peripheral-driven PRL with equal, unequal, and extensive damage to the two eyes. the PRL location is dictated by the scotoma size in both eyes. In those with equal scotomas, the goal really is to maximize retinal correspondence. In those with unequal scotomas, the goal is to optimize the better seeing eye, and if other areas are suitable for PRL development in the other eye, then the function of binocular vision is prioritized. So taking a closer look at this case, for example, with unequal central lesions, you'll see that the blue cross indicates the location of the former fovea in the worse eye and the better seeing eyes. Monocularly, the patient uses the red crosses for visual tasks. These monocular PRLs are found on the functioning peripheral retina at the border of the scotoma at a location that increases the chances for visual input. The green cross shows the functional retina that is closest to the formal fovea. So that's where the pyrophobia used to be, and the green cross is the closest to it. The purple star denotes a PRL location from the worse eye, corresponding with where the PRL from the fellow better seeing eye would fall. And so in the case of binocular viewing, the PRL in the worse eye falls in the region with a low retinal function. If we want to improve visual function in this case, we would want to choose a TRL for this patient in the temporal superior location in the better seeing eye to have a corresponding PRL in the fellow worse seeing eye that falls in an area with better retinal function. Since we don't train both eyes, we avoid diplopia in this patient, so we would only train the better eye for the new TRL, which is denoted by the green cross. It's important to recognize that PRL is a dynamic feature, and as the disease progresses, the PRL also changes over time. In this example case, as you can see, the macular disease is changing from the first visit to the third visit, and the PRL is moving together in both eyes based on prioritization for PRL correspondence and binocular vision. So we talked about fixation stability. Fixation stability is also very important for PRL and for vision. It's measured using the bivariate contour ellipse area, or BCEA, which we'll refer to throughout this presentation. The bigger the area of BCEA, the worse the fixation and worse the visual acuity. On the other hand, a better visual acuity may be associated with a better fixation and a smaller BCEA. And BCEA is calculated based on where 63% and 95% of the fixation falls. So the association of fixation stability has been shown in postoperative patients undergoing macular hole repair and epiretinal membrane peeling. And studies have suggested that the change in fixation stability from pre to post-operatively is correlated highly with visual outcomes. As such, fixation stability and PRL location may actually be used as outcome measures after treatment or intervention and to monitor disease progression in various macular diseases. So in the context of low vision rehabilitation, here's a patient with retinoblastoma who has a large BCEA or poor fixation stability with a visual acuity of 2200. You can see that at 1 year after low vision rehab, the fixation stability is improved from 96.1 square degrees to 43.7 square degrees, and the corresponding visual acuity is also improved at 20/160. In the case, in this particular case, in addition to fixation stability, you can see that actually the retinal sensitivity is also improved, and you can appreciate this on the microperimetry images that are shown here. So here's another example of the association of fixation stability with visual acuity in a patient pre and post low vision rehab. The patient improved from a visual acuity of 2050 to 2030 with a decrease in BCEA from 13.1 square degrees to 2.5 square degrees. Now going back to our case, patient A. He's a 13-year-old male with low vision since birth due to foveal hypoplasia. He could not see the board, he had difficulty reading and required aids at school. He was referred to low vision rehab with the goal of improving his distance and his near vision. On initial assessment, his distance binocular best corrected visual acuity was 20/50, near vision was 20/25 in both eyes, and his reading speed was reduced at 172 words per minute. When assessing reading speed, it's important to note that there are different cutoffs based on the grade level and the age of the patient and the expected reading speed for their specific category. So in the case of patient A, based on his grade and his age, his reading speed was deemed to be on the lower side. And these are all cutoffs based on what's reported in the literature. His microperimetry showed that his right eye is fixating in an area with a mix of high and low retinal sensitivities of 27 to 31 decibels. The red circle in the right eye shows the area of the foveal hypoplasia, which is near his PRL. The left eye has a corresponding PRL, again, also near retinal sensitivities of 25 to 32 decibels. And these areas of low retinal sensitivity are also shown with the red circle in the left eye. And that brings us to our third poll question. Which low vision rehabilitation option out of the ones listed would you offer to your patient in this case? So if you had patient A, what would you offer them? Would it be prisms, electronic video magnifier, biofeedback training, bioptic telescopic glasses, virtual reality, or counsel the patient and family that unfortunately nothing can be done further?
You know, Tina, I seem to be having some technical difficulties with this one. It's not launching.
No problem.
So unfortunately we'll have to skip it. I'm sorry.
Oh, that's okay. Okay, so we'll go to what we did for this patient. So in this case, the patient underwent biofeedback training. And with that, I will now go on to talk about some important concepts related to biofeedback training in low vision rehabilitation. So biofeedback training is a technique that increases the ability of a person to control voluntary physiological activities by providing information about these activities. Biofeedback training involves learning a new visual perception through acoustic and luminous stimuli. The goal is then to modify the acoustic and visual precepts to improve vision. And once the vision is improved and improves over time, the aim is to control the new visual function in the absence of the stimuli. We now know today that a new oculomotor loop in the midbrain is created in order to provide oculomotor control in cases where the fovea is lost or when there is nystagmus. And the goal of low vision rehabilitation with biofeedback training is to develop more attention in brain regions involved in controlling the new PRL or improving fixation. The biofeedback training done at our institution at University of Toronto uses the Maya microperimetry, which is imaged here. The Maya can be programmed for doing various types of biofeedback trainings customized to the patient. So here's a video showing how biofeedback training is done. Okay, so during biofeedback training, the patient is shown a visual stimulus. In this case, the stimulus corresponds to the blue circle, which is the TRL. And then the red circle is the original PRL. So the TRL is actually selected by the trainer for the patient. The patient is guided to look at the circle to try to control their eye movements and fixate using their TRL. The goal is to hear a long beep, as you heard in the video earlier. And that directs the patient or lets the patient know that they're actually appropriately fixating or controlling their eye movements. And so this particular video that I'm showing here is an example of what is done with biofeedback training in nystagmus patients. So in the case of patient A, Going back to the initial PRLs that we saw together in both the right and the left eyes, you can see that for the left eye, which had higher retinal sensitivity areas, the new TRL is chosen at the location with the highest retinal sensitivity, which is 32 decibels compared to the original 25 decibels. And the corresponding PRL is shown in the right eye. And this is the area outlined by the red circle in the right eye, which has a higher retinal sensitivity than the current PRL and also prioritizes binocularity. Following biofeedback training in this patient, the PRL is successfully relocated to a new location with higher retinal sensitivity. Now the PRL is surrounded by high retinal sensitivity areas, and it's located outside of the area associated with foveal hypoplasia. What is very important to point out here on the microperimetry is that the retinal sensitivity in general is also increased around this new PRL after biofeedback training. So the functional outcomes are also expected to improve as a result. Here's the right eye, which also shows a relocation of the PRL to a corresponding location to the left eye for binocular vision. And I'll point out here also that around the new PRL, the retinal sensitivity is also improved. So here you can see the good outcomes in this patient following biofeedback training. After only 4 weekly sessions, the visual acuity in this case improved to 20/20 in both eyes with a near vision of 20/16. So next is another case with idiopathic infantile nystagmus syndrome. This 11-year-old male had a distance-corrected vision of 20/50 in both eyes and near vision of 20/20, and reduced reading speed of 126 words per minute. You can see here that the fixation stability as a result of the nystagmus is poor with a large BCA area. The measured BCAs are 3.9 and 4.9 square degrees in the right eye and the left eyes respectively. And I'll let you take a close look at these images before we go to our next poll question. So now for a poll question. Based on the information you've learned so far, where would you choose the TRL for biofeedback training in this idiopathic infantile nystagmus case? Would it be temporal to the fovea? Depends on the abnormal head position, on the fovea, area with the best retinal sensitivity on microperimetry. So which one would you choose as their TRL for biofeedback training?
All right, we'll let this run for about 5 more seconds and I'll show you the results. It seems to be an overwhelming consensus here.
Oh, that's great. So everyone's been listening.
There you go.
Oh, fantastic. Okay, so most people chose the answer D, which is the area with best retinal sensitivity on microperimetry. Okay, and so with that, we'll show you what we did in this case. So the TRL in this case was chosen to be at the fovea or middle of the BCEA because it's expected to be the area with the highest retinal sensitivity.
Tina,
So the audience is correct.
can I just comment something about this?
Of
It's
course.
technically very difficult to obtain a complete microperimetry test in these cases with nystagmus. So we actually can't measure what the best retinal sensitivity is. So we suppose in idiopathic cases, it has to be the fovea. So that's why we choose the fovea. If we had the retinal sensitivity, which is best, would be even better to choose.
Thank you, Dr. Naito. And as Dr. Naito mentioned, what's really resulting in the decrease in visual function in this patient is the impaired fixation due to nystagmus, and we expect the retinal sensitivity to be normal, close to normal at the fovea, and the fixation stability is expected to improve with biofeedback training. So this patient underwent 4 weekly biofeedback training sessions for a total of 80 minutes in the better eye. Following the training sessions, his fixation stability was noted to be improved in the right eye, and the BCA decreased from 3.9 square degrees to 1.7 square degrees. And similarly, in the left eye, the fixation improved and the BCA is smaller from pre to post training. And as you can see, the BCA is decreased from 4.9 to 1.3 square degrees. So overall, after 1 month of low vision rehabilitation, the vision was noted to be better in this patient. The post biofeedback training binocular best corrected visual acuity is 2032, and binocular best corrected near vision is 2016. The patient was also able to read better with a reading speed of 129 words per minute. And most impressively, we've been following these outcomes of this patient, and at 2 years following biofeedback training, these outcomes are still maintained. Now, the impact of biofeedback training on visual functions and quality of life of pediatric patients with idiopathic infantile nystagmus syndrome has been shown in other cases and published. And amongst 10 cases, there is a consistently significant improvement in distance and near vision, stereopsis, contrast sensitivity, and reading speed, as well as quality of life. And here you can see the aggregate results for pre and post biofeedback training for these patients. Most importantly, these outcomes are maintained long-term. And so in ongoing studies at our institution of 23 pediatric patients, these improvements are noted to be sustained beyond 1 year. And this is again showing graphically the improvements in both distance and near visual acuity and fixation stability in long term amongst a larger group of pediatric patients from our low vision rehab services at University of Toronto.
So far, we have shown that biofeedback training has helped children with phobia, hypoplasia, and nystagmus. How about that for other conditions in pediatric ophthalmology? It also helps. Now let's have a look at 2 cases. This is a 15-year-old female with cerebral visual impairment, and she has cerebral palsy, significant nystagmus, and accommodative esotropia. So at her initial visit, she was using a prescription of +5 in both eyes since 2 years old with corrected distance visual acuity of 20/40 and near corrected visual acuity of 20/32. So we decided to give her biofeedback training. Here is the outcome. So before the training, as we can see in the image on the left, her fixation stability was quite poor. Her fixation scattered in the area that is slightly inferior and a little bit close to the posterior arcade and in a vessel. So a vessel in the posterior arcade. So she undergoed biofeedback training, and after the training, as we can see in the image on the right, so she was able to use a fixation point, that PRL, that's more central as we decide for her, and her fixation stability improved. So here is the outcome at 1 year follow-up visit. So her distance best corrected visual acuity improved to 20/25, which was 20/40 at her initial visit. And her near visual acuity improved to 20/20, and she was able to read very fast. And she was very happy. Here is another case. This is a 12-year-old female with Leber congenital amaurosis. She has slight developmental delay, and she was attending special classes at that point. At school, she was using laptop, but she has a contract problems, and she also had photophobia and nyctalopia. So this is her assessment. Her prescription was +5 and +4.5 with some and sorry, her prescription, here is her prescription, and her, as we can see, her distance vision was quite poor at 20/100. And she also has nystagmus with a left head turned at of 30 degrees. So here, in terms of intervention, we decided to give her a combo. So we use 5 prisms, base in, base out, trying to improve her abnormal head position. And we give her a +5 add to improve her near vision. So with the near add, her near vision acuity was improved to 20/25, and she was able to read much faster. So at the end, we give her bifocal with prisms and transition glasses. So let's look at the biofeedback training. So as we can see on the image on the left, before the training, so she was using her PRL that indicated in the yellow dots, which is a little bit superior. And based on her abnormal head position, very important to remember. So here we decide the training PRL based on her abnormal head position. So we select the point as indicated, the dark blue there. And then the image shows the biofeedback training. So she underwent 5 sections of 20 minutes in each section. As we can see in the image on the right, after the biofeedback training, she was able to use the new PRL. So here, let's look at the long-term outcome. Very amazingly, so at 7 months after the training, her binocular visual acuity was improved to 20/64. Remember that she was 20/100 at her initial visit. And at 2 years follow-up, her vision improved furthermore to 20/40. And she didn't need any prisms for abnormal head position at all, because with the biofeedback training, we relocated her PRL, and that improved her abnormal head position. At that time, she was still using +2 add for her near vision, which corrected her vision to 20/20. And very, very amazingly, so at 4-year outcome, 4 years follow-up, or she didn't need any add for her near vision at all, and her vision, visual acuity maintained, and so both for the distance and for the near, and she was very happy. We still are following her, and she's still doing very well. So based on this case, we come to learn that, so in children specifically compared to adults, so the improvement of their vision potentiate more improvement of their vision, which is very amazing.
So yes, the patients, if I'm not going to explain in detail because of the time, but some of our kids were borderline and now they can drive. They took their license because they improved these 2 lines of vision. You can go to the next, please, to the conclusion. Yes, we covered all these topics, and I just wanted to take home the message that we have the prisms possibilities for these kids. We have biofeedback training. They can go better than adults actually and boost their visual development. In the future, we're going to have more research on virtual reality, and I promise to bring next time our results from this study we're starting with CIHR this year. So if you have any questions, if we have time for questions.
Yes, absolutely. First of all, thank you for that session. I think it's incredible what you guys are doing, and the amount of impact you can have on somebody when you restore freedom, like with driving, or restore career options, this can be hugely monumental for these young people. So kudos to your whole team for that. There's a question from Dr. Epstein. If kids with nystagmus naturally adopt a head tilt to improve their vision, why don't they naturally find their best PRL?
So the brain was not able to find this PRL. It's a lack of oculomotor control, clearly, because when we train them or when we do prisms to compensate for this fixation stability, they find their way.
Great, thank you. So we'll wrap it up here. Monica, Sam, question for you guys. If someone has a patient that they want to refer to you, what's the best place to send patients for this?
We have 3 locations. We're doing this research with children at the Toronto Western Hospital. I can broadcast the fax number. We have the CNAB, mostly for adults, but we also see children clinically, Dr. Markowitz and I, myself. And at Davenport Road, we're going to leave the numbers for you. Dr. Markowitz and I will see all the patients as well.
Excellent. Well, yeah, go ahead, Dr. Markowitz.
At the CNIB, it's not the CNIB phone numbers. We have a separate office within the location of the CNIB.
Okay, thank you. So it'd be great to get those numbers out. I think you guys are doing fantastic work, and you can help a lot of children. You already help a lot of adults. You guys have been amazing as a resource for my patients and for the university. So thank you for all that you do. Manlong, Tina, Mariana, congratulations on a wonderful presentation. We don't have grand rounds next week as we're heading into the holidays. So I hope everyone has a wonderful holiday season, and I will see you all in January. Please enjoy your holidays, be safe, and get some time with your families. Thank you.
Thank
you
you.
so much.
Thank you.
Thank you, Tina and Manlong.
Our pleasure. Take care,
you.
everyone.
My
Happy
pleasure.
holidays.
Thanks. Happy holidays.
Happy holidays.